Hey there, it's Dr. Arianna here, and welcome to another episode of the Stay Juicy podcast. I just finished taping the latest episode, which was on testosterone and how that works with your libido and specifically with hypoactive sexual desire disorder. We go into kind of what it is, why it is, and different ways to treat it. What does that mean? Basically, you have a low libido and it's bothering you. Testosterone might just be one of your best friends. Now, the literature doesn't bear it all out, but I can tell you anecdotally, a lot of patients are really digging their testosterone, myself included. I am going to dispel some of the myths around testosterone, tell you what the true data shows around it, kind of what I'm seeing in my patients and in our clinic, and also just to give you some ideas of different ways that you can take testosterone and how it might be helpful in your life. So stay tuned, stay brilliant, beautiful, and juicy. Listen for this one. Okay, hello, and welcome back, everyone, to another episode of the Stay Juicy podcast. I'm your host, Dr. Arianna, and today we're talking about testosterone, libido, and really the truth around women's hormones. There's been a lot of conversation around testosterone. You may have seen it on social media, and I've been treating women with testosterone for, over a decade now, and I really think this is an area that's worth reviewing again and again. I have done one podcast on testosterone before, but I'm going to give you all some updates this time. Specifically, I attend the International Society for the Study of Women's Sexual Health conference, and I attend that every year, ISHWISH as it's called. I also attend the Menopause Society conference every year. And so these are my two conferences where I get all the juicy news around what's the latest in hormone therapy and treatments and just where we are on the whole women, wellness, menopause, longevity, all the things. So I attended that conference last month, and I've been wanting to get a couple of points across to you all so that you can at least hear a little bit more about what the researchers are saying, what's kind of new. Like I said, testosterone is getting a lot of attention now, and we've heard of it really on social media, on any kind of longevity clinic, in anywhere where someone is typically prescribing hormone therapy. And by the way, we don't call it hormone replacement therapy anymore. Just saying, in the medical community, we call it hormone therapy or menopause hormone therapy. So that's just a semantic issue, but keep calling it HRT if you must. But in the medical terminology, it's hormone therapy. And even though you may be seeing a traditional gynecologist, they may have had this conversation with you as well. But, we're hearing a lot about testosterone and how it basically kind of fixes everything for women: energy, libido, mood, brain fog, muscle mass, metabolism. Testosterone, as a general rule, has kind of been marketed as this male hormone that will kind of fix things for women. But at the end of the day, there's a lot more to it, and we're gonna dig into it today. It's a little more nuanced than just, first of all, it's not a male hormone. In our lifetimes as women, we will produce more testosterone than we will estrogen. So testosterone really is not a male hormone. Women need it just as much. And one of the things we're going to be talking about in this episode is, how do we even measure testosterone after it's been administered? Because that's really, in my practice, been one of the most confusing things to deal with, is what do I do with a woman who has, testosterone levels like a man, but she's walking around and she feels fine. So I'll give you some tidbits about that, but we're going to walk through. There's a new clinical trial on testosterone. I'm going to talk about what the actual evidence says, some of the biggest myths about testosterone in women. And we're really going to dig in and dive deep to hypoactive sexual desire disorder, HSDD. We're going to talk about what it is and the fact that testosterone is one of the number one treatments that we've identified as being beneficial for women. And finally, we're going to talk about how clinicians like myself actually prescribe testosterone safely. Because as you will learn as we get through this podcast, that there is no FDA-approved testosterone for women. So in order to get testosterone as a woman, you either have to take the male version of the testosterone and when I say that male version, you get a script for what a male would do. And then you would take a certain percentage of that. And on average, it's going to be 1/8 to 1/10 that dose. And that's where it gets tricky because, now we're kind of titrating at home. We're doing some homemade testosterone dosing. And that's why out of all of the hormone therapies, I would say testosterone is one of the number one hormones that are going to be prescribed through a compounding pharmacy, because that's really the only way that women at this point can get a measured dose of it. And that has its drawbacks as well in compounding pharmacies. Remember, these are FDA approved drugs, but their doses haven't been approved. And so there's differences in the strengths and the lots and the sourcing of the testosterone. So these can all be kind of confusing for not only the patient, but for the clinicians, myself. So let's talk about the first new clinical trial on testosterone. Not the first one, but the newest one. This was a recent randomized placebo-controlled clinical trial, and it looked at whether or not testosterone could improve outcomes for women with something called diminished ovarian reserve. Now, in a nutshell, diminished ovarian reserve is going to ultimately mean infertility. This is decreased ovarian function in women, especially under 40. And it refers to women who still may have regular cycles, but their ovaries in general have not responded well to IVF treatments. So what these researchers hypothesized was that if you gave these women testosterone, that might help the ovaries respond better to the IVF medications. Now, I'm going to start by saying, first of all, this isn't a study that ultimately is going to be as pertinent to the average, midlife menopausal woman, because we're not at this point usually dealing with IVF. But it is an interesting question, and it is some of the most recent data. So I'm going to review it, and at least you'll have some food for thought there. But what they did is they designed what's called a double-blinded, randomized, placebo-controlled trial. And this is really what we would consider the gold standard for research in the conventional medical world. Double-blinded, meaning that the participant in the research and the researcher themselves had no idea who's getting the medication or not. Randomized, meaning, people were assigned to a certain group randomly. There wasn't any bias in how people were assigned or to take the medication or to not. And it was a controlled trial. So women with diminished ovarian reserve, they either got testosterone gel or they got a placebo gel. And they did this for about 9 weeks before the IVF stimulation. And their testosterone levels rose into the upper normal female range in that treatment group. And then researchers looked at two things. One, what was the IVF success rate? And two, what was the quality of life? Okay, so let's stop there and talk about, first of all, the dosing and the response, meaning the finding of the upper normal female range. So the first thing I want to say is that in my years of practice, I can honestly say at this point, I don't know what a normal testosterone level is for women. I'm walking around some days with a testosterone of 500, which I'm not saying in any universe is necessarily a good thing. But I do have patients that when we ultimately draw their labs and look at their testosterone levels, they're just out there off the roof. One of the things that really did help me at this conference in terms of kind of feeling better about the approach of treating women is understanding that our ways to measure testosterone in the blood are not great. And the testing, the assay that we use isn't really the most accurate. So first of all, I have patients saying oh, I want to look at my levels. There is no normal testosterone level, right? There's a range, but understand even in that range that what and how we're measuring is still actually debatable. And so honestly, I'm going to go so much more with kind of what you're telling me. If you're telling me you have no libido, you have no energy, you have, you're just feeling kind of flat, in addition to the estrogen that I'm 9 times out of 10 going to have you on, then we talk about testosterone, but I'm not going to look at your level of testosterone and say, Susie has a low level of testosterone and therefore we need to give her more. It doesn't quite work that way. So in reviewing how testosterone works, we really do want to be aware of the fact that any measurement that we make of it is going to, honestly, in my opinion, at this point, a little bit more of guesswork. And we're going to really go with the symptoms. That's how we do it with estrogen. We don't look for a certain range of estrogen. We don't look for a certain number or your FSH to be a certain number. We look for the symptoms. So if you tell me I'm still having hot flashes, I still can't sleep at night, I still, whatever, itching all over or whatever your symptoms were, and I have you on estrogen, I'm going to increase your dose. Like, I'm not going to look at your labs and say, oh, well, your labs say something else. We're going to go with whatever it is that you are telling me. The same goes for testosterone. Now, that said, in this study, they did look at quality of life. And I will tell you, in that study and in other studies that have come before it, they've really not been able to say definitively that testosterone increases the quality or improves the quality of life for women. But I can tell you anecdotally that some of the happiest women I have prescribed testosterone to are my 35-plus-year-old women who actually don't need estrogen. They have younger kids. They are tired. They have no libido, and testosterone has really done wonders for them. Anecdotally, they report more energy, more libido, and just more desire in general. But the studies haven't really borne that out. Like, it really hasn't been clearly identified that this is how testosterone works. But talk to a lot of women on testosterone, they will tell you that. So if it's a placebo effect going on, so be it. There's a lot of placebo going on in terms of testosterone and how it actually improves the quality of life. I will tell you, I have a patient right now who she actually gets pellets, and we'll talk a little bit about what those are in a few minutes. But she gets pellets, and she knows at the end of that 3-month cycle with her pellet, like, she literally is dragging. Like, it's like she hit a wall. Now, the testosterone does absolutely nothing for her libido, but it does give her energy, much needed energy, and she swears by it. So no, the studies can't support it. They don't support that, but I can tell you again, anecdotally, testosterone has helped many a woman feel better with energy. And I give it again to younger women. I definitely give it to older women as well. Now, one of the reasons that testosterone is so popular is that we talk about testosterone and muscle mass and strength and all of these things. Well, there is no data. Again, when we review these studies, there's really no data that testosterone increases muscle mass in women. This is more of an effect that we are definitely going to see in men. I think the jury is still out with that. I definitely, again, personally can say that when I'm on testosterone, I can lift heavier. Like, I just overall feel a little bulkier. I don't have any evidence otherwise that it is not helping with my bone or my muscle mass. But at the end of the day, there are no studies that support that. So again, all of this is anecdotal. And that's the problem with a lot of these hormones, is that we're dealing with anecdotal evidence, anecdotal experiences, and we don't have definitive studies. But I can say almost unequivocally that the average patient, at least 30 to 50%, are going to respond positively, favorably to testosterone, whether it be through increased libido or just a feeling of increased energy. Now, the results of this study, which I kind of keep going in and out of, is that there was no improvement in the IVF pregnancy rates. The pregnancy rate for the testosterone group was 15.7%, and the pregnancy rate for the placebo group was 14.9. So there was no statistical significance there. So again, essentially identical effects, but the trial was actually stopped earlier because the research determined that it really wasn't showing any benefit. And so they just basically said, well, first, do no harm. It doesn't seem like it's doing anything positive, so let's just stop it, especially when you're dealing with pregnant women. Nobody really wants to be giving pregnant women things or want to be pregnant women things that they don't need. But they also measured the quality of life, and they used a validated tool, which is called the Ferdy-Qual. And this is a tool that evaluates emotional, relational, and social aspects of their fertility treatment. And what they found was that there was no improvement in well-being, no improvement in relationship well-being, and no improvement overall quality of life. Now, again, I'm kind of taking the results with a grain of sand because this is not the population that I'm typically going to give testosterone to in the first place. And I can speak again from personal experience that infertility patients are in a whole class of themselves. So just because testosterone did not improve the quality of life for a infertility patient really does not speak to what it could potentially do for a woman, in her 40s and 50s. So what does this mean? The study doesn't exist in isolation. It really fits into a growing body of research that really there's multiple randomized clinical trials that we're seeing a consistent pattern that testosterone does not appear to improve mood, depression, anxiety, or overall well-being. That said, again, anecdotally, talk to your friends. They will give you a different story, but the data doesn't bear it out. But there is one area where testosterone does show benefit, and that is in the area of sexual desire. So later on in the episode here, I'm going to be talking about hypoactive sexual desire disorder, or HSDD is the acronym. And it really brings us to really some of the most important things I want to talk about with testosterone. First, I'm going to bust a couple of myths because you know how I feel about the myths. If you don't, then you should check my book out called The Menopause Myth, What Your Mother, Doctor, and Friends Never Share With You About Life After 35. And we go through a lot of different myths. Myths like your gynecologist is always going to be prepared and ready to talk to you about menopause, or that your labs actually have a lot of significance in terms of whether or not you should start. So we're on to the myths still. And really, myth number one is that women kind of need this testosterone in order to have more energy and vitality. And this is a very common claim online. Like I see it, I hear it, and as I mentioned, anecdotally, I see it. But again, the evidence doesn't bear it out. The clinical trials have repeatedly shown that there's no consistent improvement in mood, fatigue, or overall well-being when testosterone levels are increased in women. And the mood regulation really, in terms of this whole menopause journey, it appears to be so much more dependent on our estradiol levels, our progesterone metabolites, and the neurotransmitters that I talked about in a previous episode around dopamine and serotonin. This is so important in our sexual desire. And we're going to get into, again, some more of the myths, but talk about how these other hormones actually, when they work synergistically with testosterone, we can see the obvious improvement. Myth number two is that low testosterone causes symptoms in women. Now, this goes back to what I started talking about initially, was that we really are not, there is no lab that I can look at and say, oh, your testosterone is low and therefore this. I can tell you I've seen women with what appears to be low testosterone, their libido's off the chain. They are feeling great. Nothing's going on. And then I have women that's with low testosterone. And I have women with higher testosterone that are like, not feeling like they're functioning well or have no libido. So I can pretty definitively say that the testosterone levels that we're seeing are not really the best guide for therapy or any type of treatment. It's always going to be your symptoms. But low testosterone is not necessarily going to cause any symptoms in women. In men, there is a clear threshold for hypogonadism. And we do see that those numbers very specific in men and when we would treat, but there is no threshold for that in women. And women, as I mentioned before, can have very different testosterone levels, but feel the same way. So testosterone is just a lot more elusive. It's a little stickier. It's not as clear as estrogen. Like estrogen, we know you take some estradiol, these hot flashes are going away. We're feeling a certain kind of way. Bim, bam, boom. With testosterone, sometimes it works more synergistically. Sometimes we don't see the effects at all like we were expecting. So again, it can be a little more elusive. But why do women with very different levels of testosterone feel differently? It's because the androgen activity in women is complex because, we're complicated creatures. It's going to have to do with receptor sensitivity, what we call the endocrine hormone metabolism loop. So that's actually the fact that hormones are shifting and going from one hormone to another intracellularly. And so we're not even able really to judge what's happening on the overall cellular level and to measure, because a lot of these reactions are actually happening within the cell. And so that's throwing some things off. And also just how we locally convert testosterone in our tissue. That's going to be different for every woman. And this is why every woman is going to look, seem, feel different with varying testosterone levels. Myth number 3 is that testosterone is a female libido hormone. And I already mentioned it before. At the end of our lives, we'll produce more testosterone than we will estrogen. And testosterone is not a male hormone. It works synergistically with estrogen and can really improve, if nothing else, its hypoactive sexual desire disorder, which we'll get into. But it really can increase the sexual desire in women, but it is not, at the end of the day, only a libido hormone. And then again, alluding to what I kind of spoke to in terms of the studies, myth number 4 is that testosterone helps with weight and muscle. And this largely comes from what we know in male patients. And this is what a lot of the problems are with our understanding of a lot of hormones and things, is that women are not little men. And so we've made certain assumptions about how things work, but these actually were not very good assumptions that we made. So the idea that testosterone is going to help with weight and muscle, that actually comes from the male physiology, but women do not experience that same, what we call anabolic response. Our muscle gain is actually more dependent on resistance training, nutrition, and growth hormone pathways. Myth number 5, more testosterone equals better sexual function. Now, actually, the opposite can happen. Higher testosterone can increase your risk for acne, facial hair, scalp hair loss, voice deepening, and clitoromegaly. Now, the voice deepening, I've again been prescribing testosterone for over a decade now. The voice deepening is irreversible. And obviously, if you are a singer or someone who, has their voice as their livelihood, they should really be thoughtful about whether or not they take testosterone and understand the side effects. Now, clitoromegaly, I thought this was funny. We've always known, basically, your clitoris gets bigger, right? Clitoromegaly. Now, I was at the conference, true story, and I was actually listening into this lecture on testosterone. I was in my room, and it was like Sunday. It was like the end of the conference, and I just decided I'm going to do it online. So while I'm online, they're talking about testosterone and the side effects and clitoromegaly, and somebody writes in the chat, and what's wrong with clitoromegaly? And I was like, exactly what I was thinking. Like, the clitoris being a little bigger isn't a big deal. Like, it's not going to hurt you. And honestly, the clitoris has like over 8,000 nerve fibers. It is the most sensitive organ in our body, and it has one purpose, which is to give pleasure. So I'm not saying go for clitoromegaly. I'm just saying clitoromegaly isn't the worst thing in the world that can happen to you. Your clitoris getting a little bigger just gives you a little more surface area for fun. That's all I'm saying. But I have definitely seen it cause back acne, facial hair, and hair loss. All of these are very real side effects that can happen. I would say the average patient does pretty well with it, but I do have some patients that, just on a very small dose of testosterone are already reporting some hair loss. And hair loss is a big, big thing for you all, especially going through this transition. So a lot of y'all are just like, I'm not doing anything to increase that, but testosterone can definitely do that, regardless of the dosing. So where does testosterone actually have evidence? Where do we know this stuff actually works? And what can I leave you with so that you understand, if you are a candidate for testosterone, or if this would be makes sense for you. So in a large meta-analysis of randomized controlled trials, so this is where they basically took a whole bunch of randomized controlled trials and they did a meta-analysis. So they kind of analyzed all of them to see, like, what is the general message? What is the general idea that comes through these studies? So we look at them kind of in bulk. And what they did is they really wanted to know, does testosterone therapy improve sexual function in postmenopausal women with hypoactive sexual desire disorder? And then what would that look like? It would look like increased desire, arousal, orgasm, sexual responsiveness, improved sexual self-image, and reduced distress related to low desire. So the effects really are modest with testosterone. In clinical trials, testosterone increases sexual activity by at least one additional satisfying sexual count per month. But for women who were experiencing distressing loss of desire, that improvement actually can be quite meaningful. So let's get into what hypoactive sexual desire is for starters. It is a persistent or recurrent lack of sexual desire or sexual thoughts that causes personal distress. Now, this is where we really do need to look at the psychosocial, the biopsychosocial assessment. We need to look at, what does that mean? I need to look at the whole person. I tell this to every patient coming through. Like, if you hate your husband, this testosterone is not going to make you like him anymore. If you hate your job, if you just, are feeling a certain kind of way, testosterone isn't necessarily the answer for any of that. So I can't fix those types of things. With the combination of estrogen and testosterone, we can generally and typically improve women's sexual desire, but understand that testosterone, again, doesn't work in a vacuum. And our sexual, like our libido, it doesn't work in a vacuum, right? Women, I say this all the time. We start here, and I'm pointing to my head, my brain. We start here, and then in our heart, and then below. I dare say men go in the opposite direction. But at the end of the day, understand that we are complex beings as women, and that this biopsychosocial factors, like what your other hormones are you going through menopause? Are you on other medications? Do you have chronic illness? Are you having pain with sex? Or do you just have really jacked up sleep? Like, these are all things that are going to affect you biopsychosocially. And those are, I would say, your biological factors. The psychological factors that would be playing a role here would be underlying depression, anxiety, body image concerns, stress, and a history of trauma. And this is so common. The depression is real. The anxiety is real. The body image concerns. I hear this a lot. A lot of y'all just not interested in sex because you don't love your body. Like, you're looking at your body and you're not feeling yourself. And it's obviously a trauma history. And then there's relationship factors, right? This is, again, part of that biopsychosocial entire assessment of someone before we say, hey, try some testosterone. We want to make sure that these other factors aren't playing a big role. So in relationships, communication problems, emotional disconnect, mismatched desires, and just life stress, right? Life be lifing. And so in women with hypoactive sexual desire disorder, which is, again, defined as a persistent or recurrent lack of sexual desire or sexual thoughts that causes personal distress. In these women, testosterone really should be considered as one of the first line therapies of choice and can be quite useful. But sexual desire at the end of the day is rarely just about the hormones. There's so many other things that come into play than our hormones, but testosterone is right up there. So what the evidence shows in terms of this meta-analysis, they looked at 8,000 women across randomized clinical trials, and it showed that testosterone therapy can improve sexual function in postmenopausal women with HSDD. However, the only evidence-based indication for testosterone therapy in women remains HSDD. Not fatigue, not aging, not brain fog. So the only indication technically for testosterone is HSDD. That said, I have lots of patients. I said it before. They love their testosterone. They have their energy. They're feeling their libido. They're feeling good. I want to talk about now how testosterone is prescribed and what's some of the easier ways for you to get it. So when we talk about prescription in real life, this is where it does get a little bit complicated because there is no FDA approved testosterone for women. So what do we have to do? We have to prescribe a compounded testosterone, or we have to use male formulations, and then we have to basically figure out how to titrate them down. And it can get real tricky trying to titrate a male dose down. So I don't even try for it. I don't even bother. I think that is just a disservice to women trying to guess how much testosterone they're getting by do this little pea size or do this much of the tube and maybe do half the tube this week, but the other half in 2 weeks. It can be all over the place, but one of the most common ways that I prescribe testosterone is going to be a troche. So a troche is like a small pill that, in this case, I call them little waxy pills. In this case, I usually start with a 10 milligram troche, and I have the patient break that up into 1/4 of a troche. The patient is getting 2.5 milligrams per quarter. Now, they're going to take the troche, put it under their tongue or right on the side of the buccal area in the mouth, and it's going to be basically absorbed directly into the bloodstream. It is not going through the liver. It's not going through a first pass effect. It's kind of like transdermal in the sense it's going to get directly to the bloodstream faster. And so we would have patients use this troche over about a month or so. If they're not seeing any significant improvement, I would say then we're going to double that dose. So now you're going to half of that troche. And typically by 5 milligrams, I'm going to start seeing some results in women. And again, they're not always good results. Some women are like, no, I have acne, or no, I felt rage. Like I felt really angry. And that is very real. I've even had male patients that have been cutting up just because their testosterone levels are got kind of high. So it does affect how we're able to engage and interact with other people. And I would say our threshold for anger. I usually say to patients, if you're feeling road rage, you're feeling like you want to kill people when you're driving, and you're feeling like disproportionately angry to situations and what you may have normally, how you would have normally responded under different circumstances, then just take a look at the testosterone, because sometimes the testosterone be kicking in. Sometimes I got to check myself and be like, okay, I think we are good with the testosterone. True story. I think I've said this also before on the podcast, is that the first time I took testosterone was a pellet. Well, actually, I think I had taken troches before. I had done some things, but I never really saw a huge effect of the testosterone. And I'm not lying. I would have women skipping into the clinic all the time. I love my pellets. I love my pellets. And at that time, I was really kind of, sticking with the whole conventional line of, not doing pellets and really trying to just color in the lines with therapies and all of the things alike. So I was kind of poo-pooing the pellets, like, oh, I think the testosterone gets too high. And I had a whole bunch of opinions about it, even though I hadn't been using it. Fast forward, I had a nurse practitioner who was studying the technique of putting in pellets. She put a pellet in. And when I tell you 2 to 3 weeks later, I was like, oh, I understand now. I understand. If a man is walking around feeling like this, if anybody is walking around feeling like this, then I can't even be mad at him. So testosterone definitely did increase my libido. It definitely, I would say, helped my energy. And the first time I took it, I honestly almost got myself in trouble because I was like, oh, this is what testosterone does. Yeah, I had to check myself before I wrecked myself. There's only so much I can say on the podcast, but trust and believe. It was popping, the testosterone, my libido. Yeah, looking at everything from the UPS driver to the mailman to the anyway, I digress. Troches. We talked about the troches. This is simple. It's consistent. The absorption is predictable. I always generally start with troches unless somebody has a different opinion or idea. I generally don't start with pellets because pellets are a lot. We take these small pellets and we make a very tiny incision with a scalpel. We do it in the office. We make this incision on your backside, and it basically releases testosterone slowly over the next several months. And they're convenient, but they can't be adjusted. Like once you put a pellet in, I tell people, I can't take it out. So I really want to know how you respond to testosterone before I give you a pellet, because now you're going to be responding to testosterone, whether you like it or not. I can't take that pellet out. Pellets can be great for some patients, but they cost more. That is a invasive, semi-invasive procedure where we have to make a small incision and bandage it up. But at the end of the day, I would tell you that the people who love their pellets. They're not stopping. And the people who felt like, oh, those weren't for me, then they just weren't for them. But everybody typically finds what their sweet spot is eventually. And then there's testosterone cream. So another option is that we can take the testosterone cream and we can apply it to the inner arm, to the inner thighs. This still allows us to make some of these adjustments, but we still, if we're using the male product, then we're still using a portion of it, a fraction. We're not exactly sure what we're getting. It's probably fine, but I think the safest bet is to have it compounded so we at least get as close to what we think the actual dosages of this testosterone. So creams can be very valuable. And finally, intramuscular injections. Intramuscular injections are sometimes a little tricky because they can really create peaks and troughs. And so, for example, my pellets have run out, but I was like, okay, I feel like I need some testosterone. I did a IM injection. I can tell I'm peaking out here with my testosterone. It's going to start coming down. I'm going to get my pellet hopefully this week. But that said, we can also mix and match. Like for me, I do get testosterone in my pellet as well as estrogen. But towards the end of that pellet, I noticed that I'm going to need more estrogen. So I usually slap my estrogen patch on within the last several weeks of my pellet insertion. And yeah, we just keep it moving depending on, again, how we're feeling, not necessarily the labs. But more testosterone is not necessarily better. And the real takeaway is that, testosterone is not this kind of universal vitality hormone that it's been marketed to be. And I feel like that you all are getting a lot of marketing these days around hormone therapy, around, all the things that you should be doing or not doing. And at this point, it's hard to know, like, well, what's true, what's not true. So what I've tried to do is just provide you with the most recent data and explain my anecdotal experience. And then you can make the decision for yourself. But testosterone is definitely one of those personal decision things that people need to walk away and feel that they've advocated for themselves. But the real takeaway again is that it does have a role. Testosterone has a role, especially in women with hypoactive sexual desire disorder. And that's basically no libido and wanting to have a libido and feeling distressed about not having that libido. And in closing, women deserve accurate science, not hormone marketing. And this is what I am seeing in terms of this hormone push with testosterone. We, as clinicians, our job is to just continue to educate the patients and continue to get educated ourselves. And this is what the problem is that if you're not going about getting the, CMEs, the continued medical education, if you're not going to conferences, if you're not doing this type of learning, then you really can't help your patients. And that's why you guys, as patients, are walking into doctor's office and they're kind of clueless or gaslighting you because they haven't really done that work. So there's a lot still that has to be done in terms of testosterone. But as clinicians, again, our job is to help you understand your bodies and make the best and most informed decisions about your health. And, with good information, you ultimately can make good decisions. So, in a nutshell, if you are feeling low libido and at the end of the day, decreased sexual desire, and that's bothering you, consider testosterone as a potential therapy. Make sure you find a provider who is comfortable in prescribing it because testosterone does get a little tricky. It can be a wonderful adjunct. It works synergistically with estrogen. I think it works so much better when you're combining it with estrogen. Like it has been very beneficial. So the data doesn't bear it out that it improves energy and brain function and all that. But when you talk to patients who've been on it for any period of time, they'll generally tell you that they're feeling a much better quality of life around it. So hopefully that answers your questions around testosterone, gives you a quick review of kind of what we talked about at Ishwish. And I will have some more episodes just giving you the latest and greatest data around hormone therapy and sexual health and menopause and all the things from the conferences I've been attending in the last couple of months. So if you made it this far, once again, want to say thank you for listening. Please like and share if this was any help for you. Please make sure to share it and definitely to like it. We are gaining traction. We're getting more viewers, and that is all on you all. And I appreciate the feedback and all the things. So keep doing what you're doing. As usual, stay brilliant, stay beautiful, but most of all, stay juicy. I'm Dr. Arianna, and I'll see you on the next one.